Welcome to Pediatric Case Review. Today's lecture covers Sanjad-Sakati Syndrome, a rare but important genetic disorder. This presentation will enhance your clinical knowledge about diagnosis, management, and long-term care of affected patients. We'll use case-based questions to reinforce key concepts throughout this comprehensive review. A 3-month-old infant presents with recurrent seizures since birth. The parents are consanguineous. Pregnancy and delivery were normal. On examination, the infant has microcephaly, depressed nasal bridge, and deep-set eyes. What is the most likely underlying metabolic abnormality? Option A, hypoglycemia. Option B, hypocalcemia. Option C, hyponatremia. Option D, hypomagnesia. The correct answer is B, hypocalcemia. Sanjad-Sakati syndrome characteristically presents with neonatal hypocalcemia caused by congenital hypoparathyroidism. When you encounter seizures in neonates with distinctive facial dysmorphism and consanguineous parents, consider this diagnosis. Always measure serum calcium and parathyroid hormone levels in such presentations. Parents of a child diagnosed with Sanjad-Sakati syndrome request genetic counseling. This is their first child, and both parents are healthy but from the same tribe. What inheritance pattern should you explain to them? Option A, autosomal dominant. Option B, autosomal recessive. Option C, X-linked recessive. Option D, mitochondrial. The correct answer is B, autosomal recessive. Sanjad-Sakati syndrome follows autosomal recessive inheritance caused by TBC gene mutations on chromosome 1. Each future pregnancy has a 25% recurrence risk. Both parents are carriers. Genetic testing and counseling are essential for family planning and prenatal diagnosis options. Pediatric Case Review continues. Which population shows the highest prevalence of Sanjad-Sakati syndrome? Option A, East Asian populations. Option B, Saudi Arabian population. Option C, European populations. Option D, African populations. Consider the epidemiological patterns of this rare genetic disorder when selecting your answer. The correct answer is B, Saudi Arabian population. Sanjad-Sakati syndrome occurs most frequently in Saudi Arabia and Middle Eastern populations due to high consanguinity rates. This geographic clustering increases autosomal recessive disorders. The syndrome is also called Kenny-Caffey syndrome type 1. Maintain high clinical suspicion in patients from these regions. A newborn with seizures undergoes physical examination. Findings include prominent forehead, depressed nasal bridge, micronathia, and deep-set eyes. These facial features are most consistent with which diagnosis? Option A, Down syndrome. Option B, Sanjad-Sakati syndrome. Option C, Pierre-Robin sequence. Option D, Treacher-Collins syndrome. The correct answer is B, Sanjad-Sakati syndrome. The characteristic facies includes depressed nasal bridge, deep-set eyes, prominent forehead, and micronathia. Additional features include long philtrum, thin upper lip, and large floppy ears. Recognizing these distinctive facial features aids early diagnosis when combined with hypocalcemic seizures. Pediatric Case Review Question 5. A 6-month-old infant with confirmed Sanjad-Sakati syndrome undergoes growth assessment. Which growth parameter is most characteristically affected in this condition? Option A, weight only. Option B, height only. Option C, head circumference only. Option D, all growth parameters equally affected. The correct answer is D, all growth parameters are affected. Sanjad-Sakati syndrome causes severe intrauterine and postnatal growth retardation affecting weight, height, and head circumference. Microcephaly is present at birth and progresses. Growth typically remains below the 3rd percentile throughout life. Regular growth monitoring is essential. What is the primary pathophysiologic mechanism in Sanjad-Sakati syndrome? Option A, parathyroid gland aplasia or hypoplasia. Option B, vitamin D resistance. Option C, calcium malabsorption. Option D, renal calcium wasting. Understanding the underlying mechanism helps guide appropriate management strategies for affected patients. The correct answer is A, parathyroid gland aplasia or hypoplasia. The TBC gene mutation affects parathyroid gland development, resulting in absent or insufficient parathyroid hormone production. This causes inability to maintain normal calcium homeostasis. Patients require lifelong calcium and vitamin D supplementation to prevent hypocalcemic complications. A newborn develops twitching movements on day 2 of life. Examination shows generalized tonic-clonic movements and facial dysmorphism. Laboratory results show calcium 6.5 milligrams per deciliter, normal glucose, and normal sodium. What is the most appropriate immediate management? Consider the urgency and severity of presentation. The correct answer is B, intravenous calcium gluconate. Severe hypocalcemia with seizures requires immediate intravenous correction. Administer 1 to 2 milliliters per kilogram of 10% calcium gluconate slowly over 10 minutes with continuous cardiac monitoring. After stabilization, transition to oral calcium and vitamin D supplementation. Avoid rapid administration. Pediatric case review continues. A 1-month-old infant with suspected Sanjad-Sakati syndrome undergoes laboratory evaluation. Results show calcium 5.8 milligrams per deciliter, phosphorus 8.2 milligrams per deciliter, and parathyroid hormone undetectable. These findings are most consistent with which condition? Analyze the laboratory pattern carefully. The correct answer is B, hypoparathyroidism. The classic laboratory triad includes low calcium, high phosphorus, and low or undetectable parathyroid hormone. Absent parathyroid hormone cannot mobilize calcium or promote phosphorus excretion. This pattern distinguishes true hypoparathyroidism from pseudohyperthyroidism, where parathyroid hormone is elevated. An 18-month-old child with Sanjad-Sakati syndrome undergoes developmental assessment. The child is not walking, speaks 3 words, and recognizes parents. What developmental pattern is most expected in this condition? Option A, normal development. Option B, mild delay only. Option C, moderate to severe global delay. Option D, isolated motor delay. The correct answer is C, moderate to severe global developmental delay. Sanjad-Sakati syndrome causes significant intellectual disability affecting motor, language, cognitive, and social-emotional development. Severity ranges from moderate to profound. Contributing factors include microcephaly, recurrent hypocalcemia, and seizures. Early intervention and special education services are essential. Pediatric case review question 10. A neonate presents with seizures, dysmorphic features, and consanguineous parents. Initial laboratories confirm hypocalcemia. What is the most appropriate next diagnostic test? Option A, brain magnetic resonance imaging. Option B, serum parathyroid hormone level. Option C, chromosomal microarray. Option D, electroencephalogram. The correct answer is B, serum parathyroid hormone level. Measuring parathyroid hormone distinguishes hypoparathyroidism from other hypocalcemia causes. Low or undetectable parathyroid hormone confirms hypoparathyroidism. Subsequently, genetic testing for TBC mutation provides definitive diagnosis. Additional workup includes magnesium, vitamin D, renal function, and imaging studies. A 3-year-old child with Sanjad-Sakati syndrome undergoes brain magnetic resonance imaging. Which finding is most commonly associated with this syndrome? Option A, normal brain structure. Option B, intracranial calcifications. Option C, hydrocephalus. Option D, cerebellar hypoplasia. Consider the effects of chronic hypocalcemia on the brain. The correct answer is B, intracranial calcifications. Basal ganglia calcifications occur most commonly due to chronic hypocalcemia causing calcium deposition in brain tissue. This may contribute to neurological symptoms and seizures. Cerebral atrophy from microcephaly is also present. Maintaining optimal calcium control may reduce calcification progression. Pediatric case review continues. An infant with Sanjad-Sakati syndrome is discharged after initial stabilization. What is the cornerstone of long-term management? Option A, anticonvulsant therapy. Option B, growth hormone therapy. Option C, calcium and vitamin D supplementation. Option D, thyroid hormone replacement. Consider the primary pathophysiologic defect. The correct answer is C, calcium and vitamin D supplementation. Elemental calcium 50 to 100 milligrams per kilogram per day divided into 3 to 4 doses, plus calcitriol or cholecalciferol. Monitor serum calcium, phosphorus, and renal function regularly. Maintain calcium in low normal range. Avoid hypercalciuria and nephrocalcinosis complications. A 6-month-old infant on calcium and vitamin D therapy for Sanjad-Sakati syndrome requires monitoring. How frequently should serum calcium be monitored initially during dose titration? Option A, daily. Option B, weekly. Option C, monthly. Option D, every 3 months. Consider treatment safety and dose optimization needs. The correct answer is B, weekly monitoring. During initial dose titration, check calcium, phosphorus, magnesium, renal function, and urine calcium weekly. After stabilization, extend to monthly, then every 2 to 3 months. Additional monitoring includes growth parameters, developmental assessment, and annual comprehensive evaluation including renal ultrasound. A 2-year-old child with Sanjad-Sakati syndrome on treatment develops decreased urine output. Laboratory tests show elevated creatinine and hypercalciuria. Renal ultrasound reveals bilateral nephrocalcinosis. What is the most likely cause? Option A, underlying kidney disease. Option B, excessive calcium supplementation. Option C, dehydration. Option D, urinary tract infection. The correct answer is B, excessive calcium supplementation. High calcium and vitamin D doses cause hypercalciuria, nephrocalcinosis, and kidney stones. Prevention requires monitoring urine calcium to creatinine ratio, maintaining it below 0.2. Management includes reducing calcium dose, ensuring adequate hydration, and possibly adding thiazide diuretics. Regular renal ultrasounds monitor progression. Pediatric Case Review Question 15. A 4-year-old child with Sanjad-Sakati Syndrome undergoes skeletal survey. Which skeletal finding is characteristic of this syndrome? Option A, normal bone structure. Option B, medullary stenosis of long bones. Option C, osteoporosis only. Option D, multiple fractures. Consider distinctive radiographic features. The correct answer is B, medullary stenosis of long bones. This involves narrowed medullary cavity with thickened cortical bone, primarily affecting long tubular bones. This finding helps differentiate Sanjad-Sakati syndrome from other hypoparathyroid conditions and reflects Kenny-Caffey syndrome type 1 features. Additional findings include increased bone density. An infant with Sanjad-Sakati syndrome experiences recurrent respiratory infections. What immunologic finding distinguishes Sanjad-Sakati syndrome from DiGeorge syndrome? Option A, absent thymus. Option B, normal T-cell function. Option C, low immunoglobulins. Option D, absent B cells. Consider important differential diagnostic features between these conditions. The correct answer is B, normal T-cell function. Sanjad-Sakati syndrome has normal immune function, distinguishing it from DiGeorge syndrome, which has thymic hypoplasia. Both conditions share hypoparathyroidism and dysmorphic features, but DiGeorge includes cardiac defects, thymic aplasia, and chromosome 22 deletion. TBC mutation causes Sanjad-Sakati syndrome. Pediatric Case Review continues. A newborn diagnosed with Sanjad-Sakati syndrome requires cardiac evaluation. What is the expected cardiac finding? Option A, contratruncal heart defects. Option B, normal cardiac structure. Option C, cardiomyopathy. Option D, valvular defects. Consider the typical systemic involvement pattern in this syndrome. The correct answer is B, normal cardiac structure. Congenital heart defects are not typical features of Sanjad-Sakati syndrome. This absence helps distinguish it from DiGeorge syndrome. However, electrocardiogram abnormalities, including prolonged QT interval, may occur during hypocalcemic episodes. Maintain normal calcium levels to prevent cardiac arrhythmias. A 5-year-old child with Sanjad-Sakati syndrome presents with tetany and seizures. Heart rate is 140 beats per minute with respiratory distress. Calcium is 5.2 milligrams per deciliter. Electrocardiogram shows prolonged QT interval. What is the first priority in management? Consider emergency stabilization needs. The correct answer is C, intravenous calcium with cardiac monitoring. Administered 10% calcium gluconate 1 to 2 milliliters per kilogram over 10 minutes with continuous electrocardiogram monitoring. Life-threatening hypocalcemia requires immediate correction. Monitor for bradycardia or arrhythmias. Follow with calcium infusion until stable, then adjust maintenance therapy. Which vitamin D form is most effective for hypoparathyroidism in Sanjad-Sakati syndrome? Option A, ergocalciferol, vitamin D2. Option B, cholecalciferol, vitamin D3. Option C, calcitriol, 1,25-dihydroxyvitamin D. Option D, all equally effective. Consider the physiologic role of parathyroid hormone in vitamin D metabolism. The correct answer is C, calcitriol. The active vitamin D form bypasses parathyroid hormone-dependent kidney activation. Parathyroid hormone normally stimulates 1-alpha-hydroxylase enzyme converting vitamin D to active form. Calcitriol directly enhances intestinal calcium absorption. Dose ranges from 0.25 to 2 micrograms daily, titrated to calcium levels. Pediatric Case Review Question 20. Parents of a child with Sanjad-Sakati syndrome inquire about growth hormone therapy. The child has severe short stature but normal growth hormone levels. What is the appropriate counseling regarding growth hormone therapy? Option A, highly effective and recommended. Option B, not beneficial. Consider evidence-based recommendations. The correct answer is B, not beneficial in Sanjad-Sakati syndrome. Short stature results from skeletal dysplasia, not growth hormone deficiency. Growth hormone therapy shows minimal height improvement because TBC mutation directly affects skeletal development. Focus on optimizing nutrition, calcium supplementation, and developmental support. Severe short stature persists despite interventions. An infant with clinical features of Sanjad-Sakati syndrome requires definitive diagnosis. What genetic test provides definitive diagnosis? Option A, karyotype. Option B, TBC gene sequencing. Option C, chromosomal microarray. Option D, fluorescence in situ hybridization for 22 deletion. Consider the specific genetic basis of this condition. The correct answer is B, TBC gene sequencing. The TBC gene is located on chromosome 1 at position Q42 to 43. Founder mutations are common in Middle Eastern populations. Testing confirms diagnosis, enables genetic counseling, and allows prenatal testing. Family member carrier screening is recommended for informed reproductive planning. Pediatric case review continues. A 3-year-old child with Sanjad-Sakati syndrome undergoes ophthalmology evaluation. Which ocular finding may occur in this syndrome? Option A, normalize. Option B, cataracts. Option C, retinopathy. Option D, glaucoma. Consider complications related to chronic hypocalcemia and metabolic abnormalities in patients. The correct answer is B, cataracts. Chronic hypocalcemia causes lens opacity, typically subcapsular cataracts developing in childhood or adolescence. Optimal calcium control may reduce risk. Regular ophthalmologic examinations are essential. Surgical cataract removal is indicated if vision is significantly affected. Early detection through screening improves visual outcomes. A 5-year-old child with Sanjad-Sakati syndrome has delayed tooth eruption and enamel defects. What is the primary cause of dental problems in this syndrome? Option A, poor oral hygiene. Option B, chronic hypocalcemia. Option C, medication side effects. Option D, dietary factors. Consider metabolic effects on dental development. The correct answer is B, chronic hypocalcemia. Calcium is essential for normal tooth development and enamel formation. Manifestations include delayed eruption, enamel hypoplasia, and increased caries risk. Microdontia and malformed teeth may occur. Management includes regular dental care, fluoride supplementation, and preventive measures. Maintain adequate calcium during development. A child with Sanjad-Sakati syndrome experiences breakthrough seizures despite optimal calcium levels. What is the next appropriate step? Option A, increase calcium dose. Option B, add anticonvulsant medication. Option C, check magnesium level. Option D, switch to different vitamin D form. Consider additional factors affecting seizure control. The correct answer is C, check magnesium level. Hypomagnesemia causes both hypocalcemia and seizures independent of calcium levels. Magnesium is required for parathyroid hormone secretion and action. Hypocalcemia refractory to treatment suggests hypomagnesemia. Provide magnesium supplementation if low. If magnesium is normal and seizures persist, consider adding anticonvulsant medication. Pediatric case review question 25. Parents request prognostic information for their child with Sanjad-Sakati syndrome. What factor most influences long-term outcome? Option A, age at diagnosis. Option B, quality of metabolic control. Option C, severity of dysmorphic features. Option D, genetic mutation type. Consider modifiable versus fixed factors.